Welcome, everyone, and thank you for participating in today's ASBMR webinar, Intelligent Exercise for Osteoporosis Patients, What Doctors Need to Know. My name is Dr. Deborah Ersick, and I will be moderating today's webinar. Before we get started, I have a few quick announcements. During today's webinar, all participants will be in a listening-only mode. If you have any questions during the presentation, please use the Q&A feature at the bottom to submit your question. All questions will be answered after the presentation. Today's presentation will be available as a recording in the ASBMR Education Resource Center. You will receive an email following this webinar with a link to the Education Resource Center. We kindly ask that you please fill out a quick survey about this webinar. The survey will appear in your window at the conclusion of the webinar. A link to the survey will also be available in a follow-up email. It is now my pleasure to introduce today's speakers, Dr. Janet Rubin and Ms. Margaret Martin. Dr. Janet Rubin is a Sarah Graham Keenan Professor of Medicine, Vice Chair for Research in the Department of Medicine at the University of North Carolina at Chapel Hill, and an endocrinologist who specializes in treating patients with metabolic bone disorders. Dr. Rubin's NIH-funded research aims to understand molecular mechanisms by which physical forces regulate the behavior of cells involved in bone remodeling. Dr. Rubin further works with UNC's School of Medicine to ensure the success of junior physician scientists and to improve and empower the scientific presence of research faculty. Ms. Margaret Martin is a physiotherapist, certified strength and conditioning specialist, yoga, Tai Chi, and Nordic walking instructor, working out of her home clinic in Ottawa, Canada. Her practice is primarily around osteoporosis and aging well with exercise. Margaret is the proud recipient of the 2011 Award of Distinction from the College of Physiotherapists of Ontario for significant contributions and achievements in physiotherapy. All of Margaret's books, courses, videos, as well as her educational website, melioguide.com, are self-funded. The Melio Guide website had over 1 million visitors in 2021. I'd now like to turn it over to today's presenters to begin the presentation. Thank you.
Hello, and many thanks to the Education Committee at the ASBMR for supporting this webinar. My own endocrinology practice is filled to the brim with osteoporosis. And most of these women, from those who are young and hale, to those who've had compression fractures, to those who are trying to get back on their feet after chronic illnesses, want to know how to exercise to prevent fractures. Doctors generally are not trained to answer this. Do we recommend walking, resistance exercise, machines? I was really puzzled as to what to say to my patients. Then last year, I had the great fortune to come into contact with Margaret Martin, a physiotherapist in Ottawa, has been working with osteoporosis patients for more than 30 years. Margaret's truly a superstar in the world of exercise with respect to osteoporosis, and she has many useful resources, including an incredibly curated website. Let me assure you, she's an expert who can help us, the doctors. So today, I'm thrilled to be able to bring you Margaret Martin and her extensive knowledge to this ASBMR webinar.
This is a real honor, Janet. Thank you for having me here.
Okay, so we decided together that we'd start from a few points from the literature, and there's a lot of it. First, I hope we can just agree that physical force causes adaptive remodeling. It's been reviewed by a lot of groups, including my own, from cells to mice to turkeys to kids, and even to postmenopausal women.
Agree. I wouldn't be here if I didn't.
So we've all gotten the idea now that high intensity resistance and impact training is important for building bone density.
Yes, we've actually known this for some time. If I go back and think about around 2000 in Germany, Dr. Wolfgang Kemmler began what was to be a 16-year study of the benefits of exercise for postmenopausal women with osteoporosis. And over that time, among other things, he showed first that they could strengthen their muscles, that they could, with exercise, stop bone loss, and with high intensity, which he referred to in the study as power training, was more effective than lower resistive exercises in building bone. And then there's also been numerous studies over the years looking at the benefits of weight bearing, everything from stomping and hopping and jumping.
Well, while we're talking about jumping, could you comment on Belinda Beck's work, which I admire so much, where osteoporotic women are starting to do some heavy lifting?
Yeah, I love her work because it's allowed me the confidence and the permission to allow to encourage my clients to lift heavier. Until about 2010, many physical therapists were quite hesitant to prescribe exercises that involved free weights for strengthening. And that was about the time when I was launching my Exercise for Better Bones book. And, it didn't take long before I was getting so much pushback from these therapists and people emailing me and saying, appalled that I would be recommending that these women should lift more than 2 pounds, even though the research was there to support my recommendations. Messages these days are much more supportive and largely due to Belinda's work.
Can I tell my patients that these exercises actually prevent fracture?
You should absolutely confidently do that. Yes. So going back to Dr. Kemmler's group, who studied the postmenopausal women, from 2000 to 2016, in his follow-up analysis during the final year, their findings showed a significant fracture protection in the women who had participated over these years in the multi-purpose exercise programs.
Yeah, this is really great stuff. And it's even more important as women get older and more frail.
Absolutely. There's another study that I'd like to share.
Go ahead.
Because especially my frail women and even my younger women, I'm not always comfortable prescribing heavy squats because I'm not there to supervise them. But there's another study that was done that allows me to strengthen their spinal muscles in another way. So this one goes back to 1984, the year I graduated from physical therapy.
Oh, I'm even farther.
Dr. Sinaki at the Mayo Clinic conducted this study with young postmenopausal women between the ages of 49 and 60 years of age who had had spinal osteoporosis and back pain. As identified on the y-axis, the women were divided into 4 groups and prescribed either flexion exercises, a combination of flexion and extension exercises, or only extension exercises. And of course, there was a control group that did no exercises. All of the participants had spinal x-rays done before treatment and at follow-up, at which time any further wedging and or new compression fractures were recorded. You can clearly see how contraindicated flexion exercises are, with 89% of the women showing either a new vertebral fracture or worsening of a vertebral fracture. Despite doing some extension exercises, the combination group fared almost as poorly as the control group. This study that unfortunately is still not well known amongst health and fitness professionals when it comes to exercise prescription. And, the most surprising finding, that supports all my work was that the extension was really where we needed to encourage our women to go to keep them from refracturing, because only 16% of that group had sustained a new compression fracture in that time period. So it's just so important to keep in mind, when you ask clients what they like to do, or you find out what they're interested in, because so many of the movements or activities that they love, like gardening, yoga, Pilates, these things all involve so much flexion, repetitive flexion movements. And they're, in their attempt to do good for themselves, they're actually doing more harm. And it's so important that they make modifications and learn to practice safely.
So let's move from there. Now that you've opened that up, let's really talk about a prescription that we can discuss with our patients. And obviously we're going to include both strength training and weight bearing. But let's talk really first about strength training, because it's so important for bone density, bone quality, fall prevention. And doctors, frankly, have little to no idea where to start.
So I agree, this is a good place to start. And to fully understand weight training or resistive training, I think it's important to understand sets and reps. On the far right, we have the endurance exercises, sitting between 12 and 15 reps. And both the American College of Sports Medicine as well as the National Strength and Conditioning Association agree that 8 to 12 reps is the range load necessary for strength training. When we get below 6 reps, we're into high intensity resistance training, which requires trained supervision, especially with inexperienced lifters that have any pre-existing musculoskeletal issues and comorbidities. You'll notice that as the number of repetitions decrease, the sets increase. And so must the load to allow individuals to fatigue within the prescribed number of repetitions. Increasing intensity doesn't always require heavier weights. It does, however, require us to recruit more muscle fibers.
So to get to fatigue, how much weight should our patients be working with?
So I don't know just by looking at them. My approach is to find a weight that allows them to safely fatigue around 12 reps. What I mean by safely is proper form, good posture, and coordination of breath, which among other things, keeps the pelvic floor protected. Over time, I gradually move them to the lower end of the strength rep range of 8 to 10 as we move towards the high intensity range. The biggest challenge I have is in teaching novice lifters to fatigue their muscles while still staying safe.
So let's just start with a squat. Tell me about resistance and squatting.
Great choice. If I only had one exercise to correct, it would be the squat, because so many people do them incorrectly and it leads to knee pain.
Yeah, and I can tell you, they're getting up out of the chair and they're saying, I can't squat because my knees won't take it.
So, and then reminding them that they're squatting all day long. Every time they get on a chair, use the toilet, get out of a car, these are squats. They've never just put them in a way where they're doing 5 in a row or 10 in a row and actually challenging themselves till they go, oh, that's hard. I don't think I can do more than X number. And those of your clients that, can do the right amount, sort of my magic number between 8 and 10, if they can do that, but feeling like, okay, at 10, I really need to sit down, or you physically, we'll see them go, I'm having a hard time getting out of the chair. Or as they're lowering down into the squat, they're starting to lose control and kind of plop into the chair. So that's a sign of fatigue. And those individuals do not need external weight to add to their squat.
So I actually have my patients squat in my office because I'm that kind of a girl, but they don't know how to squat. Can you just, because I do that, can you just tell me, how do I tell my patients to squat?
Here's a short video with a few simple tips that you could do with your patients in your office. 3 tips on the way down, 1 on the way back up. So on the way down, they start with their feet at least hip width apart to ensure that they have stability. 2 is that they're going to keep in mind stretching the space between their knees. 3, that they get with their butt behind them. So as they're going down, that they're going down in as controlled a manner and they are not plopping. They might find they can only get to here with control, and that's totally fine. They might need to have support. Once they make it to the chair with or without their arms, and you're wanting to give them one more tip on getting out of the chair, once they bring their shoulders over their knees, ask them to push into the floor, just to really push, and it helps to engage the glutes and the posterior chain muscles in really making a difference, not just with coming out of the chair, but the same with going up and down stairs. So these tips will help your patients engage their deep hip rotators on the way down and their gluteus maximus on the way up. They'll provide the stability that they need to bring their squat beyond body weight to a range that allows them to lift heavier, and it's an aim that we should all encourage them to do.
Yeah, actually, in the beginning when I met you and you told me to put weights on my shoulders. That was a really big deal. I tell my patients to do that now. So thank you for that. So while we're moving to squatting with weights, do you have any, a lot of my patients are going to these weird places and they're using machines. What do you think about machines versus free weights that you can just load onto a squat?
Yeah, so I much prefer free weights over machines because free weights is life. I mean, when we're picking up casserole dishes, it's a free weight technically. However, some people find it safer to start with machines. And one example that a lot of people like to use a machine would be a leg press. And it has been shown, there's studies showing that you can increase with the right load the bone density at the hip with the leg press machine. My issue with machines is that it doesn't mimic life. In life, if we're going to be squatting heavy, then that load is in our arms or on our back. And so we need not only the strength of our legs, but we need the strength of our core muscles. We need our postural, deep muscles. And those things don't get integrated because the machines are doing all that part for you.
That's really important. That's really important. So how do I get my ladies or even my men, to actually pick up a dumbbell?
So I think, as I mentioned, the casserole dish, so many people don't realize they're already lifting heavy, but they're just only using certain muscles. And I just need them to go, you just need, something that makes it easier to incorporate into doing exercises for your back muscles and for or for your butt muscles, things on the posterior chain of the body. And sometimes, using a weight is a lot easier than a 5-gallon bottle of water. So,
yeah. So as you've told me before, lift heavy so that life feels easy. So I just took that from you. It's a great motto. We're trying to lift heavy. And actually for patients on osteoporosis medicines, we know that lifting heavy, it's just published in the JBMR again by the Beck group, that high intensity resistance and impact enhances the effect of the anti-resorptive medicines that we prescribe.
And this is really great. And I've seen this clinically, and this is actually might be the study that we need for physicians to start encouraging people to lift heavy, because our patients actually need to know that it doesn't need to be a choice. And our physicians need to know that it doesn't need to be a choice between meds or exercise, but together they work better.
So yeah, totally agree. So now we, the doctors, are sitting there in the office with our patients. How do we get to the subject of exercise and let them know that we're interested in what they're doing? What do we need to know? What do we need to do?
So I think putting yourself in their shoes is really helpful to start that conversation, in the sense that so many people that reach out to me with osteoporosis after they've gotten their diagnosis, they are so frightened and they're so afraid to move. Some are even being told that you can fracture rolling over in bed. So you can imagine they're just like, even paralyzed in bed, which is totally the opposite of what that I need them to do, or you need them to do. We now need them to move, but to move safely. So, as they're waiting to see, all of you, to talk to them about their bones and to direct them where how to stay safe, they're doing the one thing that they can do safely, which is surfing the internet. And they keep seeing, you need to strength train and you need to weight bear. And that's great, but they're hoping for some guidance, because usually that's all they get. And they kind of get mixed messages, and then they're kind of confused.
I gotta agree with you. I mean, I see it all the time.
Yeah. So then I hear that they're all excited. They're telling me they're going to see the specialist, but then they go, but they never talk to me about strength training or weight bearing. They just talk to me about drugs. Maybe considering something about recognizing or recognizing exercise as being important. Maybe even asking them, what type of exercise have they chosen to do, or do they like to do? And then that would lead you, their answer will help lead you into a conversation or a short discussion about what exercises are best for them, what things to watch out for, to be careful for. Even just little tiny, 2 minutes would just it just opens the door and gives them permission.
Okay, so that's great. That's actually kind of what I'm doing with my patients. And when we get to the end, I'd like to have 3 exercises that I can tell my patients about. Okay, so now let's move on to cardiovascular exercise. I call it cardiovascular, it's good at it. And I frequently I do this many steps per day. I walk 40 minutes with my dog, and I'm happy with those answers. After all, 5 sessions of aerobic activity to improve metabolic, cardiovascular, it's good, right?
Absolutely, yeah. And like you, I'm excited that they're doing something, but I'm not always happy with what they're telling me. So I try to find out a little bit more about what is the quality of the steps that they're taking. So if they're walking, are they, mindfully going, oh, I'm going out for a brisk walk? Or are they just walking for the sake of walking and having it more of a leisure walk? If they tell me they're doing a 40-minute walk, I'll say, do you know what distance you're covering in that time? That gives me a lot of information about the intent that they have. And I also can then play with the variables of helping them move faster. But if they're with a dog, then I always ask them, are they leading the walk or is the dog leading the walk?
So I love that we're talking about dogs. They're, to me, both a boon and a bane to their exercise. And the bane is tripping and fracturing. How can we help our patients not to fall when they're out there on the dog run?
Well, 2 things, especially when they have little dogs, if that little dog is always dictating the walk and stops suddenly, then, I just tell them, make your walk with your dog as short as possible so that, you're attentive to the dog gets to do what he wants to do. You bring the dog back, then you go for your brisk walk. If it's the type of dog that's like pulling them, I'm just honest with them and I say, either you do obedience school for the dog, or you let someone else take the dog for a walk, because oftentimes women will just do things because they don't want to impose on other family members. But I'm like, it's just not worth the risk.
So I will use that advice for my many dog lovers. My patients are really pretty proud usually of the hours that they spend walking. Do you have any advice regarding that time versus speed that they should be aiming for?
Yeah. Thanks for the question. So usually, if somebody, I'll get the same sort of clientele as you going, oh, when they start mentioning how long, it's always between 40 and 60 and sometimes even more. So then I try to encourage them, could you fit in 2 shorter walks within the same time? I don't want them to do more total time, but if they can make those walks shorter, and there's 4 reasons why I like those walks to be shorter. So 1, in a shorter time, it's easier to walk at a brisk pace. 2, they'll ensure that they're not as fatigued, and therefore that reduces their fall risk, and that's very important. And then to ensure that they still have time and the energy to do their strength training exercises. And then 4th of all, there's some fascinating research on mesenchymal stem cells. And I learned this year, and it was mind-blowing for me, that the more often you can stimulate these stem cells, the more responsive or more mechanoreceptors develop on their exoskeleton. And it was just like, for me, just mind-blowing.
Well, actually, my lab did that research, so it's nice for you to talk about it. It's another hour that isn't appropriate here. But I will say that when we published that, I actually changed how I exercised on the weekends. So instead of doing, 90 minutes of exercise, I started exercising in 2 bouts. And it was great. I did feel stronger. I could go longer. So you didn't need to hear that, but that's true.
That's great to hear.
So, so you're recommending 30 minutes per day of endurance kind of walking?
When it comes to walking, or what choice they have for aerobic or cardiovascular, because generally the recommendation is something that brings their heart rate up for that cardiovascular benefit. But for our osteoporotic women, I think it's the quality of those aerobic minutes that count.
So what do you mean by quality?
So I think we really need to encourage weight-bearing over non-weight-bearing activities and activities that promote healthy posture.
Well, that raises a question because my patients are very confused about what weight bearing means. Some people think it means they need to carry a weighted pack.
So we have to educate them because I hear the same thing. It is very confusing for them. But I'm going to grab this book because it's high enough for you to see. I like them to understand the concept of impact. And so if they're walking, they're going to be landing relatively softly. There's not a lot of impact. But as they walk more briskly, or they're stomping upstairs, or they add, even if it's not the entire walk, but portions of the walk, where I'll say to my real newcomers to brisk walking, okay, pick this light post to that light post. That's where you do your brisk walk. You're very and then a more comfortable pace, that sort of thing. But so important is that ground reaction force that we're trying to introduce gradually into their life. And I just usually use the book or the desktop to demonstrate it.
So I better sit up a little straighter. So let's return to extension flexion, to the gymnast researchers, which is something you've taught me. What about extension in these kind of exercises?
Yes. So most women, I want to say in our era, because I used to teach aerobics. And so now, I still hear my age group, 60 plus, still enjoying aerobics as the way of getting their cardiovascular exercises. But it's so unfortunate. And it's even worse now because I see it through all the Zoom videos that are out there or YouTube videos on aerobics, where everybody's still going into flexion moves. And these are just moves that have been around forever. And people aren't really thinking, oh, maybe I shouldn't be bringing my seniors into flexion. And then when you have the chair classes, I think most offerings of chair classes, especially for ambulatory adults, is more because of liability issues than that they're healthy for the adult, because it puts somebody into flexion just by virtue of being in these flat back chairs. And sitting onto itself is more compressive on the spine. So add the two together and it's a bit scary.
Okay, so we want to recommend both strength training and weight bearing. Is there enough time in the day?
Yes. But, at a minimum, I tell my women, if they want to make an impact on their bones through exercise, that I need at least 30 minutes a day. If they have 30 minutes, they can alternate their weight bearing days of aerobic and their strength training days. If they have 60 minutes, all the better. They split it in two in the course of the day, and they have time to do both the aerobic and the strength training.
Okay, so great. Well, we're doing everything. And my guess is 60 is a high ask for a lot of people. Is there anything that you would discourage?
But in regards to discouraging sports and activities, which I hate to discourage, I would, in the moderate to high fracture risk, discourage people from doing the contact sports. And I know those of you listening going, okay, really, in their 60s. And I'm going, yes, I have girlfriends that are on 2 hockey leagues, actually, and they're in their 60s and they're super fit.
Amazing.
Yeah, it's really great. And then, we just joined a pickleball league, and I was looking around the court and going, whoa, I think I would actually discourage anybody on that court and especially if they're playing on cement, because there's just far too many risks of a fall.
My doctor friends are really interested in hip protectors. Have we advanced from strapping pillows around our hips?
Okay, Janet, you're really giving up your age here. So yes, we have. And, if you go to the snowboarding Burton site or mountain biking sites, all the young athletes are wearing them today.
Really?
Yeah, it's really cool to see. And it's actually been a real buy-in when I send the site to my clients and they're like, ooh, it's kind of like they see themselves in their granddaughter's shorts, but the hip protectors that are out there right now are largely of the fabric that isn't very breathable because they're often more for winter sports. But there are some that have cotton, and as soon as they're actually I'm in transition to finding a good one, and as soon as I do, I will have a blog on it and have it on a YouTube video to let people know.
Fantastic. So Margaret, while we're talking about hip protectors, one of the things that you said I really should mention to my patients is the subjects of balance and agility. So let's go there, since we know those are so important for falls and fractures.
Yes, of all the chronic health conditions that exist, balance training probably has the most impact on mortality and morbidity in persons with osteoporosis. And I tell my clients, they're going to either fracture through repeated microtrauma, the repeated forward bending and unsafe loading, or they're going to fracture by a fall, which we'll call as macrotrauma.
So I've actually been skeptical that a person could actually improve their balance, but in preparation for our discussion today, I searched PubMed, and of course it's been studied, and a lot of research shows that you can improve balance.
Yes, Janet, very good. And just like hip protectors, the area of research in balance and fall prevention has evolved. And there's a lot of us baby boomers that are costing the healthcare system a lot of money because of fractures. And so there's a lot of research going there. Of recent, there's been a Canadian-Norwegian joint study that was published in 2020. And they actually specifically looked at individuals with osteoporosis who had a vertebral compression fracture. And they did a 3-month supervision of a multi-component resistance and balance program, in which they found, of course, improved strength, which we would have expected, but improved balance as well as reduced fear of falling.
Well, those are great objectives to look for. So how do I approach this with my patients?
So I'd make sure you just say a few words like, be sure you do some balance training. And then don't forget to add, between two stable objects, because safety is paramount, especially when they're just learning to get their balanced legs under them.
So as a physiotherapist, or I'm sending somebody to a PT person, how do you test their balance?
Yeah, so you anticipate that somebody would start with static balance training. And there's, depending on someone's functional level, different tests that exist, the Berg balance, the Fullerton balance, there's a lot of different established balance tests that are there. My clientele tends to be ambulatory community dwelling adults, which the Fullerton Advanced Balance Test was designed for. And I really like that test, those tests that are in there. There's 10 of them. I use about half a dozen of them because it allows me to turn the test into an exercise based on the results.
So once you figure that out, how do you work on this? What kind of work can our patients do?
So, as I said, you take a test and you can go, okay, this is where they're at. They can do it with their eyes open, but if they close their eyes, they're already falling over. So we need to do the little steps in between. We encourage them to occupy their eyes in different ways, looking side to side, up and down, tossing a ball, ways in which they can't just focus on one spot. And then gradually, you start introducing dynamic balance. So for some, they progress really quickly within a week, depending on their strength. And, for individuals that have to build their strength alongside with their balance receptors, then, it's a little bit slower progress. But then we always try to go in the direction of dynamic balance next. Things like basic stepping, forward, back, side to side, because stepping strategies are really important. And then moving on to, more advanced, even balance agility skill drills. And you'll see football players and soccer players do them because they're really effective. And you can have older people do them, but just at a toned down level. People like to sometimes incorporate dynamic balance into more enjoyable activities that have a nice social element, like Tai Chi and dancing. So these are all ways to encourage your client if you hear them, talk about what they might be doing and go, oh, that's really great for your balance, that kind of thing.
Yeah, and that's great, but it's always getting worse. We're losing our sight, we're losing our hearing, we're getting more frail.
Sure. That is the course that life goes into, and all those things seem really negative. But when it comes to our balance, we can still impact and improve balance. I mean, I've worked with 97-year-olds, and, you can move the dial even within a few minutes, and you could see them already start to be able to hold the position a little bit longer, be able to step more confidently forward and back. And, they start to see this within minutes, but within, a week of consistent training, they actually start feeling the difference.
Well, that's reassuring. And I certainly hope that the physical therapists that I'm referring people to are following this kind of practice. So, Margaret, talking about things that can upset balance, many of my patients have lumbar scoliosis, which increases as they age, as you know, from processes like osteoarthritis, and this can be compounded by vertebral compression fractures. Many of these patients are unwilling to exercise because of back pain, or even worse, because their doctors have told them, don't load your spine.
So these individuals, I know, hesitate to exercise, but they absolutely should exercise. It's going to help reduce their back pain. And ultimately, if they want to keep on living involves loading their spine. The critical part is how they can do it safely. And so let me explain what I mean by that, starting with some research that was done actually a long time ago. And this actually appeared in the very first edition of the Journal of Spine, published in 1976. There's a paper by a Swedish orthopedic surgeon, the name of Dr. Alf Natkinson, and it was entitled The Lumbar Spine, an Orthopedic Challenge. Is filled with helpful charts and images showing the relative changes in pressure or load on the third lumbar disc obtained from intravital disc pressure measurements on live subjects. The very first chart shows relative change in pressure with muscle strengthening exercises compared to standing, that is shown at 100. The ever popular leg drop exercise comes in at 150, the Superman at 180, and the sit-up at a whopping 210. On the other extreme, we have legs supported up for abdominal co-contraction, which is a gentle 35. In the second chart, you see common daily activities. Every single one of my vertebral compression fracture patients tell me that getting up in the morning is the absolute worst. Transitioning from supine to side lying is hard, but when they first stand up, they're reminded of their disability. We know that discs rehydrate at night, and that intradiscal pressure is the highest in the first 2 hours of the day. So I think this is what they're feeling. Looking at all these postures, you see my hesitation about seated exercises, especially when it involves forward bending. The two worst things people can do is to pick up and put down their weights, be it their exercise weights or their groceries or their laundry, incorrectly, which includes the Mrs. Smith that comes into your office and takes a seat, as she commonly does, placing her purse from her lap onto the ground beside her. So all of these charts and this data helped me as a young therapist when I was treating individuals with discogenic back pain. But when I started looking at the x-rays of my osteoporotic patients and seeing how common the biconcave deformities were, I knew I needed to consider posture if I was going to help keep them safe.
So looking at your chart, I don't see any twisting data there. And a lot of our ladies are being asked to twist during their exercises or even when they go out kayaking, which not many of them do, but the wood chop exercise. Should I caution them to avoid these kind of activities?
Yes, absolutely, you should. And in a nutshell, spine unloading twists are much safer than loaded twists. Activities like you mentioned, kayaking and wood chopping, are more risky because of the repetitive nature. And poses that involve loading with end range overpressure should be avoided, even with a client that doesn't have a vertebral compression fracture. With individuals that have vertebral compression fractures, I really discourage any loaded rotation. And the supine twists are done with a reduced range of motion.
Well, that's important to know. I have so many patients with vertebral compression fractures, although it does seem extreme.
Yes, I agree. But let me share a study that will help you understand my clinical decision-making on this topic. This goes back at a study of 2017, a finite element analysis study comparing the biomechanical differences between a young healthy spine and an older spine with only one lumbar vertebral fracture, and it was at L1 for this particular study. So stress stimulations were conducted on each of the spine models, and they examined the loading effects of axial compression, flexion, extension, lateral bending, as well as axial rotation. They compared the two based on the application of equivalent vertebral stress. And the comparison showed that vertebral stress concentration increased with all stresses in the vertebral compression model.
So that's concerning. Are there any movements that really stand out?
Yeah, like it was like, alert, alert when it came to compression and axial rotation was very alarming on the levels of compression, and really supported the hypothesis that secondary vertebral compression fractures are not caused solely by bone fragility, but possibly also by the increase in the vertebral stress concentration that occurs around the initial compression site.
Yeah, so that kind of recalls to me that graphic that we discussed first in this conversation, showing that that flexion exercises not only are not helpful, but might even lead to more fractures.
Yeah, so let me bring this chart back for a moment to refresh everybody's mind. And I was thinking the same thing as you, but in reverse, as to how protective extension exercises were. And when I came across another finite element study, and this one was published in 2021 in the journal Spine. It was an analytical biomechanical study looking at paraspinal muscle volume and the effects of the muscle volume on the load of the lumbar spine. They concluded that the greater the paraspinal muscle volume, the lesser the pressure that was exerted on the lumbar spine, concluding that increase in paraspinal muscle volume would lessen lumbar spine degeneration. These two finite element analysis studies support the importance of intelligent exercise prescription for individuals with osteoporosis, especially those who have vertebral compression fractures.
So, Margaret, as a doctor with a limited amount of time in the office, are there 3 exercises I can tell my patients really need to be part of their regimen?
Yep. There's, okay, these ones are easy to do. You don't need a lot of space or any weights. So you already know the first one. It's the squat.
Yay!
And the second one is the heel raise. And to do the heel raise, we traditionally would have people put their hands in our hands, depending these days how comfortable you are with that. But it allows us to assess how much they're pushing into the hands, how much they're using, the assist of their arms to even lift their heels off.
Interesting.
Yeah. So, but failing that, you have their hands on a stable surface and just observe if they can lift both heels equally. And, for testing, we would do 10 repetitions. It used to be 20, but people are getting so weak in their calves that the normative data is dropping. And, with your young, old, and more active, I would encourage them to try a single leg heel raise. The third exercise would be some sort of plank. Planks do not need to start on the floor. And you'll notice that, we have examples of planks on the wall, planks on, lower surfaces, and you just invite more and more gravity as people get stronger. And another thing on planks, they're great for upper limb loading, which we just don't do enough of, for encouraging good postural alignment while maintaining good core strength.
So, Margaret, I can't tell you how much I think of you when I go to clinic on Wednesdays. And now I have 3 quick exercises that I can call to mind to counsel my patients. And I'm hoping that our conversation here can be a call out to my fellow physicians to let their patients know that we think our exercise is important and will lead to improved function in their daily lives.
Well, we now know beyond a doubt that exercise is important for bone health, but that intelligent exercise is critical for allowing our patients to reduce their incidence of ever getting a vertebral compression fracture, and certainly if they already have one, of getting consecutive ones, because the quality of their life depends on it.
So 40 minutes is a brief amount of time to distill your decades of work with your patients, but it's a start. Thank you for everything you've taught me in the last year and that you've allowed me to make available to our listeners here today. So thank you. And I'd also like to shout out to Richard Martin, your husband, for putting together our discussion pieces. So now on to the questions. And Margaret, thank you.
Well, it has really been a pleasure and an honor to have had this opportunity. I thank you for all your work that you did to make this a possibility. And I'm looking forward to questions.
Thank you so much. We've had quite a few really excellent questions in our Q&A. So I think several people have asked if you could please share the articles that you talked about in the talk.
Yeah, no problem. We'll send it as a PDF or whatever is easiest for you, Deborah.
Okay, excellent. We had several questions that all seem to talk about OsteoStrong, the program OsteoStrong. And so the first comment was from an anonymous attendee. And it said, can you comment on what we should say to patients when asked about standalone exercise programs, in particular OsteoStrong? Also importantly, how do we make our conversations about exercise movement more inclusive? Are there ways to discuss movement or exercise that might remove some psychological and physical barriers that they face?
Ooh, that's 2 big questions. So we'll start with OsteoStrong, and those of you with shares in OsteoStrong might want to go sell them after my comment. But I have real concerns with OsteoStrong. First of all, it's not an exercise program. The closest component of it that comes to exercise is a vibration platform that some of them have. It's a franchise, so not every franchise will have the same equipment. But those that I have spoken to who have used OsteoStrong, where there have been vibration platforms, the vibration platforms are not in the safe category. They are very high intensity vibration platforms. So it really concerns me that people are being invited into somewhere that is supposed to be safe for their bones, but it's really quite traumatic for their bones. And other body parts, as Dr. Clinton Rubin, wrote in his article on vibration platforms and the hazards of them. Sorry, I forgot the title wrong. But the other thing in regards to making exercise more inclusive, that's something I try to do with my website, and I tried to do with my book as well. So rather than make it all about, the person that can, get down and do like the push-up with the twist and the single leg, stance, I have 4 levels in everything that I introduce. So, even of late with my YouTube videos, I'll do 4 exercises for your legs at a beginner level, 4 exercises for your legs at an active level, 4 exercises for your legs at a athletic level. So, and then even the book has an elite level, and the elite and athletic tend to be more on the preventative, and the active and beginner tend to be more for the individuals who are already at a higher risk. So I hope that answers the question.
I think staying on the topic of OsteoStrong, you already touched, Laura Ryan had also had a question about the vibrating plates that I think you addressed. There was another anonymous attendee that asked, it says, OsteoStrong is a group of gyms around the US that advertise heavily to osteoporosis patients that its short program of exercise, less than 10 minutes once a week, can result in large 10 to 15% improvement in bone density, exceeding what can be achieved by anti-osteoporosis medications. Do you have any further comment on that?
Yes, so actually Belinda Beck, who's been doing such great research, she actually did one looking at axial compression. And you remember the last study I talked about in terms of axial compression, especially with our women who have vertebral compression fractures. And it's just like alarming that we would even want to impose more axial compression. But OsteoStrong isn't an exercise program. As I say, it's more of a walk into a machine and they compress you. And so when Belinda did a similar compression, and she compared the amount of vertebral compression fractures that occurred with the individuals that did the axial compression versus those that did the high intensity lifting that she'd been doing, there were more fractures, alarmingly more fractures with the axial compression. And I have not seen any independent studies done out of OsteoStrong.
And I think it's important to say, people really want their exercise to increase their bone mineral density, and it possibly may. I think the younger you are, the more chance you stand. But for me, with my patients, I want them to be strong so that they don't fall, so they know how to move. And that's actually more what I'm driving at when I'm trying to get them to exercise, is function and strength and don't fall.
I think you're touching a little bit on a comment made by Susan Ott. She said exercise does not increase bone density very much, but do you think that there is a fracture reduction independent of the bone density?
Yeah, I think that the beginning of our talk, she might have come in after that, but the beginning of the talk, Dr. The Ellergan studies that over 16 years, so a short term is not going to impact bone quality as much as long-term exercise. And that was shown in an earlier study done in Europe, where they just compared bone mineral densities that were identical in a fracture group versus a non-fracture group. But in the non-fracture group, the women had been active all their life and their bone quality was so much better. So.
Okay, excuse me. One last question about OsteoStrong. Michael Rothman asked, can you please send any patient-directed websites that we can share with patients? How do you advise about OsteoStrong in those types of programs? So I think you addressed the second portion, but maybe it's an opportunity to pitch another website.
Can I, maybe I should answer that since I have nothing to do with Margaret's website, but I have been looking for these kind of things on the web for so long. So, and I just haven't found it. I didn't like the Canadian one. The US ones don't have any exercise, our national foundation. So I think there are some amazing things on Margaret's YouTube channel. And I show it to my patients a lot. You can search it for balance, you can search for agility, you can search for how to do a plank, and it's really easy to pull up. So I have nothing to do with it, so I guess I can answer that. There are probably other ones. I think the Melio Guide one is really excellent.
If I can just add, for those of you who have clients that really aren't interested in exercise, they can still find a lot of guide to moving safely. And I try to, whenever I have my clients and they come in and go, oh my God, you fractured like that. I try to do a video just going, okay, this is how to move safely in your garden. This is how to we're putting one out in the next couple of weeks on how to move safely with your grandchildren, because I have clients now picking up little babies from the ground and they're telling me, oh my God, they're back and they're concerned and then they have back pain and, and yeah. And then obviously there'll be one pickleball soon because the lady beside me yesterday had really bad back pain, but she was picking the ball up after her game, but yeah.
We're kind of coming to the end of the Q&A, so we just have time for a couple more questions. Vina Tan asks, she says, I am from Margaret's camp and have challenges getting doctor friends and physiotherapists to conduct these much needed high intensity quality exercises. Any advice how to convince the other medical physio camps other than through scientific publications? I show people the bone clinic work and videos as much as I can to convince them. I'll be exploring Melio Guide after this. Thank you.
I think, the reason that I wanted to get Margaret to do this and the ASBMR to do this is because people don't talk to their patients about how to exercise, doctors don't, and their patients are disappointed. And we're losing an opportunity to really change their lives. Now, some people will follow through better. I think, if they're searching out Margaret, they're going to follow through. A lot of us have very, little old ladies who can barely get up from the chair. But if we can get them to get up from the chair, we've really made a change in their lives. So hopefully people will start to think about that maybe a little more than they have. That's the goal of this session.
Okay, Nancy asked if Margaret recommends weighted vests in general.
And not in general, but I do recommend them with somebody who has good posture and has not had a compression fracture.
Okay. And there was a question from an anonymous attendee said, for our patients who have limited mobility, do you just suggest beginning with exercises lying supine like Sanaki, as opposed to seated to improve extension of spine? Any ideas for how to practice some extension, even in a seated position, like while we are watching webinars, for example?
Yeah, there's, so, even just doing what we call an elbow press, I'm going to back up, where you are, if you're pushing into the chair behind you and engaging your back muscles, something as simple even as tucking your shoulder blades together. Yeah. So, and the Sanaki extension is actually an active level because it's fairly tough for people to do. So I don't actually start with that. In my beginner program, I have exercises that lead them up to the Sanaki prone extension.
And listen, we know you guys are all doing squats while you're watching this. So, we can see through the TVs.
Someone else asked, an anonymous attendee asked, I love to kayak. If I keep my back straight with no twisting, which I do, can I continue to kayak?
So you can't not twist, and you should twist. I would encourage people to have really good hamstring flexibility, because if you have good hamstring flexibility, then you will maintain an anterior pelvic tilt as opposed to a posterior pelvic tilt. By maintaining your anterior pelvic tilt, you'll be able to maintain your lumbar lordosis. If you can have a lumbar lordosis, you'll have a better spinal alignment, which is going to allow you to rotate. With kayaking, you generally don't rotate at your end range. So it's more the base is what I'd focus on through the hamstrings and then posture.
Okay, I think we have time for one final question. There were two different people that kind of talked on the amount of time recommendation. One was from Laura Jan Gregorio, and the other one was an anonymous comment. She wrote, where is the 30-minute a day recommendation coming from in terms of bone health? I would not recommend people do moderate, high intensity strength training daily. Major muscle groups should be trained 3 days a week max with rest in between. I think the other person's comment was doing 7 days a week of training versus 3 days per week. What was your comment on that?
So totally agree. One should not do the same muscle group every day. And even as I get older, I find doing the same muscle group more than twice a week is plenty. So all my programs are broken down so that you're doing a little bit of exercise every day. So if you're doing something on the Monday, you're not repeating that till the Thursday, the Tuesday, Friday, the Wednesday, Saturday. And then the 30 minutes allows you to have a warm up, a cool down, throw in some balance. So that's where the 30 minutes, it's what has worked for me and my clients. I don't know if I answered all those questions. Yeah, sorry.
Well, this concludes today's webinar, and I would like to thank Dr. Rubin and Ms. Martin for a great discussion. As a reminder, this webinar will be available on the ASBMR Education Resource Center at asbmr.org/education. Please also be sure to fill out the survey and provide feedback on your webinar experience. Thank you again, and we look forward to your participation on future ASBMR webinars. Thanks so much.
Thank you.